So now let's move on to some physiology. This is the bulk of the cardiovascular section. These concepts can be pretty hard to understand, but they're important to know, not just for the exam, but also for the amount of patients you will see with cardiac complications. A good understanding of cardiac physiology is absolutely necessary. So let's jump right in with cardiac output. So we know that cardiac output is defined as stroke volume times the heart rate. This is a very, very simple concept, and I'm sure that I'm repeating things that you guys already know. So the most important thing to remember about cardiac output is actually the concept behind the equation. If you remember the equation, that's great. You can use it to break it up into its individual components and reason through any question that might be presented to you. So cardiac output is just a measure of the volume of blood that the heart can pump out in a given amount of time. So this is the amount of volume per beat, stroke volume. And then the cardiac output is dependent upon the rate, which is the heart rate. This is the simplest way to calculate cardiac output. Another way to do so is the Fick principle. Fick was just some dude that used this physiologic principle to calculate cardiac output, hence the name. It can be indirectly calculated by measuring oxygen consumption and is based on the fact that oxygen is extracted from tissues at a rate proportional to blood flow. Let's write in Fick's equation. So Fick said cardiac output is equal to the rate of oxygen consumption divided by arterial oxygen content minus venous oxygen content. Now, what does this even mean to us? Let's think about this in a more basic way with an example, and it will become really obvious to you. So let's say someone has heart dysfunction in a way that their cardiac output will decrease or be lower than expected. Blood is not flowing at the normal rate through the systemic circulation and back to the right side of the heart. Essentially, blood is going to take much longer to be delivered to the tissues and come back to the heart. This can be directly interpreted as it will just be hanging out in the tissues much longer than expected for a normally functioning heart. Tissues will have a greater opportunity to extract oxygen from the blood that is being delivered to them because blood is not flowing out and away from them as fast as it normally does. So for example, we have a vessel in our microcapillary network. The flow of blood through this network is decreased because we have heart dysfunction. That means that the amount of time that oxygen has to be pulled out of the vessel and into the tissues will increase. Blood that is now going to leave the tissue is obviously venous blood, and it has a very low oxygen content because all the time this tissue had to extract oxygen from it. And that is why the venous oxygen content in your equation will be very low. Now you have to do blood gases to obtain the arterial oxygen and venous O2 oxygen content values. And you also need to measure expired air to get total oxygen consumption. So this is measured with expired air. And that is to get how much oxygen is being consumed by the tissues. And then this is from our ABG and VBG being arterial blood gas and venous blood gas. As you can tell, this is incredibly inefficient. No one will ever do this. But on your exam, it's fair game because it's not a real patient. It's just the physiologic concept and principle that you have to understand. So this method of calculating cardiac output is rather impractical to say the least. But remember, your exam is not about practicality, it's about fundamental concepts. So do not get discouraged if you don't feel like you will actually ever see this. So back to the equation. So for example, someone that has cardiac dysfunction will not be moving blood as fast through the systemic circulation. Blood will be sitting in the tissues a lot longer than you would normally want, and more oxygen will be extracted by those tissues. This will decrease the venous O2 content in our equation, and when you subtract a very small number from the arterial O2 content, you get a very large denominator. So if we have cardiac output and our denominator is a larger value, no matter what our rate of O2 consumption is, this will automatically decrease the value that we calculate for cardiac output. And this should make sense, because the cardiac output is the reason why the venous oxygen value is so low, because the flow is incredibly inefficient and it gives the tissues a lot of time to pull out all the oxygen they need. And that is how you get a decreased cardiac output using Fick's principle in someone that has cardiac dysfunction. So the next equation that we need to discuss relates three important things: mean arterial pressure, cardiac output, and total peripheral resistance. Mean arterial pressure is calculated by a couple of different equations. You can say that mean arterial pressure equals cardiac output times the total peripheral resistance. If this equation looks familiar, it's because it's really just a basic equation of fluid flow, where pressure equals flow, which is Q, times resistance, where flow is cardiac output and total peripheral resistance is just resistance. Remember, the total peripheral resistance is the resistance provided by the small arterioles that precede large capillary networks. The I will explain this further in a second. Mean arterial pressure can also be calculated by summating 2/3 of the diastolic pressure plus 1/3 of the systolic pressure. Now, why is this the case instead of just adding the systolic and diastolic together and dividing by 2? I mean, it does say mean arterial pressure. Why do they call it mean arterial pressure if the calculation does not include finding the mean between the two? I'm not sure about you guys, but no one really ever explained this concept to me, and I was always confused about how exactly mean arterial pressure is defined. Mean arterial pressure represents the pressure in a single cardiac cycle. Our heart spends a lot more time filling itself than emptying itself. The diastolic period is a much more important or larger percent of the cardiac cycle. Mean arterial pressure represents the pressure in a single cardiac cycle, and the fact that our heart spends a lot more time in diastole is represented the fact that 2/3 of the equation is diastolic filling period. Now there's another equation that we can also discuss that is very important, which is Holt's pressure. Now this is incredibly simple: systolic pressure minus diastolic pressure. So basically, Holt's pressure is just defined as the difference between systolic and diastolic pressures. Why is this important? This is important because a high value, termed a wide Holt's pressure, is associated with certain pathologies, a major one being aortic regurgitation. We will discuss this when we hit the murmur section of the chapter, but we will briefly discuss an example here. So the Holt's pressure is directly proportional to stroke volume. The best way to consider this is an example. So let's say you have a bicuspid aortic valve, so that when you're ejecting through your aorta, you normally have a tricuspid aortic valve, remember? And bicuspid aortic valve is a congenital defect that's associated with something such as Turner syndrome. Now over time, this valve will get pounded by this systolic outflow, and normally you have 3 valves to bear that type of shear stress, but because we have a bicuspid aortic valve, you will get the wear and tear changes associated with being in that position of always being subjected to those high systolic pressures much sooner than you would anticipate. So over time, you will get fibrosis and calcification of that bicuspid aortic valve. Now what does that do to the ability of that valve to open? It will make it stenotic and very non-compliant. It's not going to want to open for you. So the blood that can be ejected across that valve will significantly decrease because you go from a functional valve to a stenotic, calcified, not very flexible valve. So the amount of blood that can be ejected across the stenotic bicuspid aortic valve will be much less. So we have decrease in our stroke volume. This decreased stroke volume will directly lead to a decrease in the systolic pressure, also decrease the Holt's pressure, because the systolic pressure is what we are subtracting the diastolic pressure from in our equation. And that is why you can say that the Holt's pressure is proportional to stroke volume. We can also say that it's inversely proportional to arterial compliance. Now what does this mean? So you'll be often taught that patients will have a change in their normal hemodynamic pressures around age 55. And what do I mean when I say that? Well, when you age, the systolic pressure will continue to rise, while the diastolic pressure levels can remain even, or they'll actually decrease, which gives you a increased pulse pressure. Well, that just doesn't make any sense. Why would our systolic pressures increase and our diastolic pressures decrease? Shouldn't they both be doing the same thing? Well, this is where you have to consider age, and you have to consider the components of arteries. Arterial compliance is dependent upon the amount of elastic and collagen fibers in the aorta. So let's clear this. In our aorta, the ability of this wall to expand when a systolic ejection is occurring is dependent on the components of elastin and collagen. As we age, we lose these components. Our fibroblasts are just getting burned out. They're much less efficient at producing collagen, and we start to lose a lot of that collagen that we made before. So this drops the compliance of our vessel. Great, what does that even mean? What am I trying to say? Well, whenever we have this systolic ejection, decreased compliance means that the vessel cannot stretch and bounce back as well. Think about it like a rubber band that is hardened after leaving it out in the sun for a long period of time, just like aging. This means that in systole, the vessel will not be able to expand as much. So note that there's less expansion, and this causes two things. One, the pressure created by that initial ejection of blood into the aorta is very high. So you have a really high peak in your systolic pressure. Because in a non-compliant vessel, you're introducing volume into this chamber that is not going to be able to expand very well, so we increase pressure very quickly. Number two, we are not able to pump as much blood into that aorta because this vessel is stiff and it will not expand for us. So we have a decreased volume that will be ejected into that vessel. This causes a decrease in stroke volume. With less blood in the aorta after systole, this means that our diastolic pressure will also be less, because our diastolic pressure is dependent upon that volume in the chamber, pushing it against those vessel walls. So this is why in the elderly population you can see a wide pulse pressure, because we lose compliance of our vessels, meaning that when we eject blood into the systemic circulation, particularly the aorta, you greatly increase the pressure very quickly, and you have a decreased systolic ejection ability, meaning that there will be less blood in those vessels, which are already very stiff, causing a decrease in your diastolic pressure reading. This is also why patients with atherosclerosis will have very high systolic values compared to diastolic readings, because atherosclerosis does the same thing to the compliance of that vessel wall. They cannot expand as easily and adapt to those increasing pressures. So if you understand this concept, then you can easily apply it and reason through some of the other examples of situations which increased pulse pressure can occur. So remember, we said pulse pressure is just the systolic minus the diastolic. So in a situation such as hyperthyroidism, obstructive sleep apnea, and exercise, we can all see increased pulse pressure. So hyperthyroidism, which is increased T3, T4, obstructive sleep apnea, and exercise, we will see increase in the pulse pressure. Now why? Well, we know in hyperthyroidism that thyroid hormone is a very potent transcription factor, and it will cause induction of an increase in transcription of beta-1 receptors, particularly in the heart. And we all know that this will increase our ability to contract. So we will be contracting at a much greater force during systole. And this means that we will increase our systolic pressure, therefore widening pulse pressure. Obstructive sleep apnea is basically the same situation, because just like in hyperthyroidism, we stimulate our sympathetic nervous system. The way that this happens is much different. Remember, in obstructive sleep apnea, a person either has a defect in their soft palate that will compress their airway and ability to take in oxygen, or it can be central, which means that there's an intrinsic defect in the signaling that causes them to breathe. Either way, a person with obstructive sleep apnea will increase their carbon dioxide 2 levels because they're not expiring as well, and they're also decreasing their oxygen retention because they're not breathing in as well. So remember, when you accumulate carbon dioxide, it crosses blood-brain barrier and it dissociates eventually when you form carbonic acid via carbonic anhydrase into a proton and bicarb. Now what's important here is this proton. The proton stimulates the chemoreceptors in the medulla. This will stimulate the sympathetic nervous system to increase contractility because the brain senses that it is hypercapnic. It has way too much carbon dioxide in it. And it needs your heart to step its game up, to perfuse the brain parenchyma, to help wash out some of the carbon dioxide and provide oxygen. Now exercise activates the sympathetic nervous system directly. Same mechanism. You activate the sympathetic nervous system, which will increase the contractile force of the heart due to beta-adrenergic stimulation. The last equation is systolic volume equals N diastolic volume minus N systolic volume. And this should make perfect sense. So the amount remaining in the chamber after we fill it, subtracted by the amount that is left after we empty it, should give you the amount that is ejected.